Okay, got it. And so today I want to talk to you about the chest wall cases, but the focus is really on the special techniques involved with these cases. One is using breath hold for chest wall, and then the virtual rod and chain. This is something that one of my co-workers came up with for patients that need rod and chains, but was not simulated with the actual metal rod and chains. Now I want to talk to you about using volumetric modulated art therapy for chest wall. And last, I want to talk about electron chest wall. So for chest wall using breath hold, sorry about that. We do breath hold on left breast and left chest wall patient. It has shown to reduce those so by doing a breath hold, we're able to increase the volume at the same time, push the chest away from the heart, thereby reduce those to the heart. So here in this, see the fusion image, it's just showing you the difference between the breath hold and the fusion and the free breathing scan. You can see how much the heart is in the free breathing closer to the free breathing. So to do our breath hold.
Hey, Coy, talk a little louder if you can.
Okay. So to do the gating, our physicists used a real-time position management system by variant. And with this system, we have an infrared tracking camera. This camera tracks this reflected marker. And basically, when you track the reflected marks, it basically tracks the patient breathing pattern. And so we have a breathing trace or breathing pattern by the patient. And so once the patient stabilizes his or her breathing, then we ask the patient to hold the breath. And when the breath, you get this flat line or the breathing trace. And once the line flattens out, what we want to do is set the threshold, which is the area in between the red line and the blue line, and so that the breathing trace is roughly in somewhere in the center of the threshold. And this threshold is what determines when the beams is on and when the beam. So typically we use gating for left breast and left chest wall patient, but over here we start using more breath hold for right breast and right chest wall patient. So you can see here on this patient here, this is a right chest wall patient. And so with the free breathing scan, I mean, this patient volume is very small, and because of that, the liver pushes up superiorly. And so we use this scan to set up our treatment. Then a lot more the liver would be in the treatment field. So we breath hold on this patient. So when we did the breath hold on this right chest wall patient, you can see we're able to increase the lung volume and then at the same time push the liver down. And so we will be able to reduce dose to the lung and to the liver. And I will go over this plan a little bit more in details later. But before I go on to other chest wall cases, I just want to kind of briefly go through like how we set up a chest wall and here at MD Anderson. And so we get the patient simulated, and we want to position the patient supine in a molded cradle with the cradle flattened out on the affected side to prevent lateral attenuation and allow for skin marking. And then we use a slant bore with the appropriate angle to help flatten out the sternum and the supraclav area. And what we want to do is avoid using too much slant angle, because this can increase the amount of lung in the supraclav treatment field. And then we want to position the patient's ipsilateral arm out of the treatment field and prevent the skin folds in the axilla area. And then the patient head is away from the affected breast. So during simulation, our therapist also create some setup ISO center for us. And so here is this thing called the ISO blue. And the ISO blue is where we actually localize our laser to. And it is placed in the lung tissue region, but it's not a stable point. So what we have is another point is the first set red. And the first set red is placed approximately mid-sternum at some depth to create a consistent setup and leveling point. And then we also have a shift point in green, and this is placed to provide a table shift reference point. And so what we normally do for to make sure the setup is correct is set the patient up to first set red, and then lower the table to the second set. And then we also generally give the therapist the lateral shift to the ISO blue. And then of course we take films to verify doing the setup correctly. In this point we also have the superclap mark ISO. And usually what we want to do is set the superclap mark ISO center below the clavicle head. But as you can see in this case, this right chest wall breath hole case. And the therapist did the superclap below the supraclavicular head in the free breathing scan. But of course when we put the coordinate in the breath hole scan, then we are not where we want it. And so the point in the pink is where superclap setup ISO center is. And this point is just below the clavicle head. And this is also where we set line inferior border for the superclap fill. And this helps ensure that the supraclavicular and the infraclavicular will get adequate dose. So commonly we want like the 45 grade, which is the 90% of the prescribed dose, to get coverage to that depth. And then the superclap also is on the CT slide where the superclap fill and the tension fills match. For the superclap fill, when we create this fill, we use the gantry angle around 15 degrees. For example, 5 degrees for the left superclap fill and 15 degrees for the right superclap. And the reason we want to angle a little bit is to avoid the trachea, esophagus, and spine. And the medial is close to the midline, and the bottom border, like I mentioned before, is below the head of the clavicle. The lateral block shield minimizes the dose to the humeral head, and the medial block shields the patient's trach and esophagus. You can see a diagram. Where we put the inferior border superclap, like I mentioned before, is just to make sure that we are covering all the lymph nodes for the superclap and the infraclap lymph nodes. And then we also have a field called the IMC field, which helps to treat memory lymph nodes, which I will discuss a little bit later. So once we did the superclap fill, now with the tangent fills, to treat the chest wall, what we want to do first is to create a non-divergent border between the tangent fills and the superclap fills. And to create that non-divergent border, normally what we do is create an external contour on the same slide where we have our final superclap treatment ISO. And this external contour can provide a non-divergent edge in the same plane as the CT scan. And what we need to do is rotate for that external contour until it becomes one line like you see up there. And now we know that we've created the non-divergent border. And then we draw along the external contour to create that non-divergent edge. So to continue with the tangent fills, we also rotate the gantry to create a non-divergent deep border between the two medial tangent fills and the tangent fill. And then we also rotate the collimator on the tangent fills to reduce treatment fills. And we want to limit this to 1 and 2 cm of lung. So next we have this IMC field. The IMC field is an electron field that we use to treat the internal memory lymph nodes. And with the C field, normally we want to start with the gantry rotation around between 10 and 20 degrees, but 15 degrees is what we tend to go with. And the IMC field, we want to set it around 105 SSD just to make sure, do we get clearance with the cone. And then the IMC border by the tangent, sometimes we match it with the tangent field on the skin, but sometimes we do a 3 to 5 millimeter overlap between the IMC and the tangent field just to help heat up the cold triangle area, because we want typically 35 gray line to cover that area, and we don't worry that the patient might recur there. And then the field is basically the same as the tangent field, and usually I want to keep the width of the IMC field at least 4 cm wide. Prescription. So usually what I'm treating the tangent, superclap, and the IMC field all going to 200 centigrade per fraction for 25 fractions. And then for the physician also like to use the bolus between 3 to 5 millimeter every other day for 2 to 3 weeks, and then they're going to reevaluate the patient, usually with how red the skin is. And so typically we don't plan the superclap field. We just use the same superclap field as before, and then we make sure that the therapist would put the bolus on that day. Now for the tangent fields, we basically take the tangent plans and then just create another plan and create a bolus, and then just recalculate that plan with the bolus to get the new mono units. So once the primary is done, usually the physician likes to use the medial and lateral chest wall, and normally it would be 200 centigrade per fractions for 5 fractions using 6 MeV electron. So here in this example, this is that right chest wall case that I've shown you earlier. So we have our primary tangent field, medial tangents and the lateral tangents, and then you have the superclap field, and then the IMC field. And you can see here on the superclap field we have the contour, the infraclap nose contour in purple, and this is where a physician wants to make sure that we cover that with the 90% of the prescribed dose. And then for the IMC, what you see in orange is the internal memory lymph nodes contour by the physician. And again, we also need to buy the 90% of the prescribed dose. And since it's going to 50 gray, so they want to cover with the 45 gray line. So when this plan was planned, what we normally want is we start out with the tangent fields, and we want to basically try to optimize that first, and usually wedges to help to get the coverage that we needed. And then we also do like a field reduction by closing the jaw to reduce the hotspot. And usually we want to get the 110% hotspot as small as possible. And then for the super field, to get the coverage to the depth that we needed, you can use, depends on the patient thickness, of course, you can use 6x or 18x. Sometimes we mix 6 and 18s, going to appropriate Dmax just to get the coverage that we need. And then on this, because of the patient anatomy, the IMC field, we actually have to use a very high electron energy of 16 MeV the entire way. But usually the physician, if we have to use 16 MeV for 25 fractions, they worry about the skin dose. So here, generally, we would do a 4-to-1 ratio of photon to electron. So we would treat like 4 fractions of electron to 1 fraction of photon every week. And then special in this case is, even with 16 MeV, we're a little bit shy of the depth that we needed to cover the lymph nodes. And so what they doing that supplement fill over here, and basically we just add enough dose in there to make sure that to get the coverage that we needed posteriorly for those IMC lymph nodes. So here I'm just showing you like all the fields that we have for that case, where we mix the IMC, and then for the superclap, in this case, we actually have to use 18 MV to get the depth that we need. So here I have the views of the first sagittal and coronal view of that plan. And so 50 gray is the prescribed dose. And what we do is for the chest wall area with the tangent fields, we want to make sure the 49 gray in yellow cover at least the chest wall well. And then for the superclap area, again, for the superclap, we want the 90% isodose line, which is the 45 gray in pink, to cover the depth of the intraclavicular fossa. So in this case, we want to cover the IMC target, what you see here in purple, with the little margin, because the physician worried that when you use a bolus, that line might go up anteriorly and we'll miss the depth of that we needed for the intraclap contours. So usually you can have the contour by the physician as a rule of thumb. If the pectoralis minor muscle is covered, then you can all your lymph nodes to the appropriate depth. So here we have more transverse slide, and here is that here on the pink, which is the 45 gray. Again, you just want to make sure that we're covering all the internal memory lymph nodes. And then another thing we look at is the 30 line. And that 35 gray line, the physician likes to cover at least 2/3 of the tissue in that cold area, the cold triangle area, so that just to help the patient from recurring. So here you have more images. And so this is the dose volume histogram of my plan. And so we're able to meet all the heart and the lung constraint for this patient. And so because we did breath hold in this right patient, so I'm sure we lower the lung dose and the liver dose. I'm sure it would be a little bit higher, or I don't know how much higher it would be if we didn't use a breath hold scan on the patient. So next I wanted to tell you about the using the virtual rod and chain. So here I have this patient. And so actually we stimulate the patient, we set the patient up for the superclap field, we set the tangent fields up, create the non-divergent border, and then we realize a lot of her arm is actually in the treatment field here. And I mean, the physician didn't like that at all. I mean, but the thing is, if we can't really lower the inferior border of the superclap field because that would increase the dose of the lung. And so what you want to do is somehow, we thought about maybe angling the non-divergent border. And so, so you have the images on the right side. To angle the non-divergent, we probably need to do saw and chain to get this. But of course, the patient was stimulated with the rod and chain, the middle rod. So one of our co-worker, Tony Bonatati, he came up with this idea of creating this virtual rod and chain. But before I go into that rod and chains, I want to kind of just go over the original metal rod and chain. So here in this image, you have this metal rod attached to the metal chain. Usually during simulation, the physician would place this rod at an angle where she wants the matched border between the superclap and the tangent field. And once the patient had been simulated, we bring the patient into our planning system, and we would contour the rod and the chains. And again, the rod is determined the superior border of the tangents, or the match line between the tangent and the superclap field. And here you have the chains. So we contour the chains, and the chain attached to the rod. But one thing is just to make sure during simulation that the chain must hang in a straight line without any obstruction. Here we have the skin rendering of the rod and chains here, as you can see. the angle that we get by using a rod and chain. So in this our image, you can see without any couch kick, the rod and chain are not aligned. By rotating the couch until the rod and chain overlap, this will create an edge along the rod and chain. And so now a block along the rod and chain to complete the non-divergent edge. Now about the virtual rod and chain. So of course our patient, she would simulate without the middle rod and chain. So how can we get the, the angle that the physician wanted? So what we end up, so with the virtual rod and chain, it creates a non-divergent edge that is not in the same plane as a CT scan that we normally do. And this allows adjustments to be made during virtual simulation without rescanning the patient. And you only need 2 contours to do this. So first, for the virtual rod, you just create like a small contour near or the base of the clavicle. And usually now we just want to make sure it's at the bottom of the clavicle head. For the virtual chain, we create contours similar to the look like, and we place the virtual chains like on this patient just below, on the slide just below the arm. So here we have our representation of the rod in red, and then in like a teal color. And so the yellow line just kind of represent the angle that we're going to end up with. And then on the right, you can see now that the virtual rod and chain are not, because we haven't kicked the couch yet. And so now we rotate the couch until the rod and the chain basically align with each other. And now you can draw a block, a virtual rod and chain, to create that non-divergent edge. And that non-divergent edge by the virtual rod and chain gives the coverage of the external contour, but angle edge of the rod and chain. So here you just see that the yellow-green line just show where the external contour edge would have been. But this is just showing you the difference between the non-divergent border before and after using the virtual rod and chain. For the superclap field now, if we use a rod and to match the superclap field with the tangent, we need to rotate the collimator for the superclap field so that it will match the edge of the tangent field. And of course, the physician look at all the blocking for the superclap field again, just to make sure that it blocks according to like how. So for this case, here we have the setup fields. So of course we have our regular tangent, medial, and lateral tangent fields, and then you have your superclap fields, and then your IMC fields. And of course, I'm not going to go into the planning details because it's very similar to the last one. All the criteria of coverage are the same. One thing I want to point out is that in this case, it's the left chest wall. And then for our IMC field, we actually split the IMC field into 2 fields, the upper IMC and the lower IMC. And so usually for left chest wall case, the physician like to use a higher energy on the upper IMC field to get the coverage that we need. And then for the lower IMC field, usually we just want enough electron energy to cover the tissue needed. Usually the coverage is just anterior to the muscle. And by using a lower electron energy, we're able to reduce those to the heart. So this is just the 3D view of that case with rod and chains. And then the main thing about this is the rotation, the non-divergent between the tangent fields and the superclass field. Okay, so next I wanted to discuss with you about using VMAT for chest wall case. Normally we don't do a lot of VMAT for chest wall or breast cases, even only on certain cases that we can't use the normal setup we do with our chest wall cases. Then the physician, might want to use VMAT for these cases, like the one I present to you. But before I present a VMAT chest wall case, there are a couple of things I just want to talk about with VMAT planning in general. One is the use of the couch. It's important to know what type of couch that the patient will be treated on. For like you have these IGRT couch, and with these IGRT couch, these couches have the metal rails on each side, like in the traditional couch, so you don't have to worry about it being attenuated through those metal rails. And so with the IGRT couch, you can do almost a 360 arc rotations for VMAT cases. So if you have a GRT couch, then you can do, like, for example, with a clockwise arc, you can do from 185 to 175 degree. And then for the counterclockwise rotation, then you can go from 175 to 185. I have seen people use as close from 182 degree to 178 degrees. So here I have a picture of the traditional couch, the old couch where I work at, and because it has these metal rails like you see on its side, even though we slide into the middle prior to VMAT treatment planning, but our physicists are worried that we still might rotate through these rails, and so they give us a rotation that feels comfortable that we will completely avoid these rails. And so for clockwise rotation with the traditional couch, they want us to go from 205 to 155, and then 155 back to 205 or counterclockwise. For VMAT planning, sometimes we like to overlap the degree of rotation by a couple of degrees. So 153 to 207 for counterclockwise for a full arc patient. Oh, just to know that we don't do full arc for chest walls or breast cases. I'm just mentioning the allowed rotation you would if you have a certain type of couch. Here's another image of the traditional couch with the rails from the bottom. So another thing with VMAT is normally we like to rotate the collimator. Normally rotate the collimator between 10 to 15 degrees to minimize intra-leaf radiation leakage. Of course, you can rotate the collimator more or less. This depends on the size of the tumor bed or the target. Okay, we have this VMAT chest wall case, and with this, the patient, when we simulate the patient, we have no intention of treating the patient with VMAT. And then also during simulation, this patient, we couldn't do breath hold on her. She couldn't tolerate it. And so we end up with this scan, and as you can see, the heart is very close to the chest wall. We couldn't really do a regular what we would normally do patient, because to avoid a heart, the tangent fields has to be pretty steep, and then that would make the IMC field probably very wide, and then the cold triangle area between the IMC and the tangent are probably going to be in the area where it's very thick. And just to get the 35 gray coverage, we probably end up having to use very high electron energy, And then by doing that, you're going to increase the heart. And so the physician wanted us to try using VMAT on this case. Another thing to point out on this patient is because we didn't know that the patient is going to, we're going to use VMAT, and then so we didn't really position both of our arms up. And so the challenge on this, because that arm on the same size as the treatment area is kind of down, and that's going to basically give us a little bit difficulty in planning this case. And I will go over it a little bit later. And so the physician likes to treat, to have two targets. One is the CTV going to 45 gray, and then the second CTV going to 40.5 gray. We didn't have to do any extra margin on this, so there are no PTVs on this case. The one thing with breast walls or breast, the physician needs to contour all the walls that he or she wanted to cover with the, whatever prescription dose that they want. So in addition to the contour or the contours, we would contour the heart, the right, the left lungs, create a total lung, and then also in this case I just contour the core. I mean, it shouldn't be a problem, but went ahead and contour the core. And then next I create the CTV sub. And what the TV sub is, I had to take the CTV that by the physician and take it out the build-up region. It's 3 millimeters from the external or the skin. And then also end up doing is create like a 2 millimeter gap between the CTV 45 sub and the CTV 40.5 sub. What happened is that I learned that usually for VMAT treatment, if you have multiple targets, and if one target is surrounded by another target, it's very hard to get very homogeneous distribution. And so if you put a gap in between the two targets, it creates a nice plan. So in general, if a target is surrounded by another target, then you should put a little gap in between the two. But if it's just a budding where it's not surrounding, then you don't need to put a gap. So on this, after I knit the C-tubs, then I create a 5 millimeter ring around the total targets and 3 millimeter gap between the ring and the total targets. And then below, I have my normal tissue contour. So for this case, I would like to use only 2 arcs to cover all my targets, but because of it's low, and also it was cut off during simulation, I can't use the same rotations from the bottom as I could the upper portion where the arm is, and so I have to split into 4 arcs. The 2 arcs going for the bottom portion, and then 2 arcs for the upper portion of the targets. So for the lower arc, there's a clockwise arc with it going from 310 to 130 degree with a 3/7 collimator angle. And then another lower arc, this one is counterclockwise with a starting from 132 going to 308 with a 13 collimator angle. And then for the target portion, I have a clockwise arc that rotate from 310 to 60. I would rotate more, but because the arm was cut off, so I couldn't have more rotation to have. And so with field C, collimator angle is 13. And then for field D, the lower arc, this one is counterclockwise with a gantry going from 62 to 308 with a collimator angle at 347. Now for field D, I actually have this was a posterior fill with an arc from the back, but because I'm limit of the by the arm, and also because I have the traditional couch, I can't really start further back close to the 180 degree. And so I try using, I end up with a lot of hot spot stripping from the back, and it didn't look good at all, and I wasn't even really getting the coverage I need. So I changed the fill D to an interior arc, and I used the 18 MV on that fill, and that helped posterior coverage that I needed for the portion where the superclap is for this patient. So here it's just showing you the IMRT parameter screen where we set our all our arcs and all our treatment fields. The main thing is at the beam, you want to make sure you go through each beam that you have the appropriate rotation direction and the appropriate starting and stopping angle for each of the beams for VMAT training. This is a picture of my objective for this case, and with treatment planning, usually I noticed that you don't want to put too many objectives up front. So usually I only start out with like maybe all my targets, maybe a core expand. In this case, I have the ring and normal tissue, and I would run that first. And I'm trying to get the coverage as I need it for those targets first, and then after that you introduce your critical strength in the objector. And I've seen that it definitely work better that way. But somehow the plan doesn't look good at all, everything up front in the beginning. Here, we have the dose distribution for this VMAT chest wall case. And so 40 gray in red is covering the red target, which is our 45 gray CTV, and then blue is the 40-50 centigrade covering that sky blue target. Another thing with VMAT is, you should push the normal tissue and your critical structure, and generally you have to push them a little bit harder than you would the IMRT plan. And in this case, I pushed the quite hard just to get as much the low dose out of the heart and the lung, and at the same time trying to get the coverage that I need to cover the target. So here are some transverse slide of this treatment plan. And so we got pretty good coverage on our 40.5 gray CTV, and then we also got good coverage on the 45 gray CTV. So this is more transverse slides of this case. So here the dose volume histogram. So this patient, we couldn't do, at where I am, we couldn't do breath hold VMAT. But in some other centers, I know that they can do VMAT with breath hold. And I'm sure that if this patient was get VMAT with hold, and we were able to lower the heart and the lung dose. But overall, with these, it's not so bad at all. We're able to meet the dose and the heart constraint, even though we couldn't do breath hold on this patient. I just want to discuss with you about electron chest walls. And so you use electron chest wall for patients that are very thin. Patient anatomy is so thin that you couldn't treat it with the regular photon tangent and superclap. So for electron chest wall patients, during simulation, again, we would position the patient's supine in a molded cradle. The slant board is an angle to flatten out the sternum and superclap. Ipsilateral position at 90 degrees out the treatment field. And then we want to turn the head from the affected breast to expose the nose and the neck. So during the simulation, the physician will use wire at the CT simulator to delineate the appropriate field, border, and the surgical scar. Once we CT scan into the treatment planning system, we would contour all the wires and change the density to 0. And we do this because the wire can attenuate electron beams. And actually for the previous chest wall cases where you have the IMC and the tangents, we generally also contour all the wires out of those patients too, because you have the IMC field with electron. So typically, to set up the electron field, you would have the IMC field, you would have the central chest field, and in blue we have the lateral chest wall field. Those are all electron fields, and we usually treat them at 5 cm SSD just to help ensure that we don't have any clearance issue. But you're able to maybe get away with treating the IMC field at 100 cm SSD. But usually just check with the physicist to make sure that we have clearance for the therapist case. Another thing to be aware of is that for the lateral chest wall field in blue, we want to avoid having more than 35 degrees apart from the central chest wall field. Because you can see if you have more than 35 degrees, you're basically just increasing the overlapping area between the two fields, and you're just introducing more hot spot into that area. So we try to avoid having more than 35 degrees between those fields. And then for the superclap field, same thing apply. Normally we would like to simulate the patient, place the superclap mark isocenter just below the clavicle head. And then we want to match the superclap inferior border, and it's going to match with the field, the superior border of the IMC, the central chest wall, and the lateral chest wall field. And then again, we want to start out with a gantry angle around 15 degrees for the superclap field. You can see here, this one is a little bit different. We actually blocked a little bit of the portion below by the bottom mid border, and what they worry is that about the lung node. So what they end up doing, block that portion and treat that portion with the IMC field. Like you can see here on this skin rendering, they brought the IMC field higher than the central and lateral fields. So on this case, so we have our 3 IMC fields, electron fields, and then we have our superclap field. But once again, because there's a lot in the superclap field, so in this case, the physician actually treat part of the that area with photon, and then in pink here you have the electron field. So what they end up doing is do a 3-to-2 ratio. In this case, 3 treatment with electron fields and then 2 photon fields, and hoping to basically to reduce the lung dose at the same time get the coverage that they needed to the lymph nodes in the superclap area. And so all the fields are all the field edges are matched on the skin surface, and then they want to jump the electron fields every week, laterally 5 millimeters. So again, the field acts on the skin surface, and then the junction between the electrons are shifted laterally 5 millimeter each week, and we recalculate the mol units at every 1 cm interval. So usually at junction 2 and 4, we would need to recalculate our mol units. No really necessary for the junction shift. So for the electron chest wall prescription, so usually for the IMC, central chest wall, lateral chest wall, and the superclap, they all go to 200 centigrade per day for 25 fractions to a total of 3. And usually we don't have to renormalize too much, so usually we keep these at 100%. And then after that, the physician would come back and boost the patient 10 to 16 gray to the surgical scar, to the IMC nose, and superclap or infraclap area as needed. So here you have the dose distribution. And so our goal is to have the dose distribution for the IMC central and lateral chest wall covered by the 90% of the prescribed dose. So again, this is we want to make sure that the 45 gray line is covering the chest wall tip just interior to the ribs, and we want no hot spot greater than 15% above the prescription dose. So as you can see here, we have this, if you can see that blue dose line, that is the 10% hot spot. And you see it's right where we have the overlap between the central chest electron field and the lateral electron field. And if you make that angle bigger, then you can have a bigger hot spot there. So now we just have some transverse slides showing you the coverage for this case. So for the IMC field, which is the field in the middle, we have using 6 MeV at a 100 cm SSD setup. And then the central field, we was able to use 4 MeV at 100 cm SSD. And then the lateral field, we also use 4 MeV, but this one we set at 105 cm SSD for clearance. So here more the transverse slide. So you can see here, I mean, we have a nice coverage. It covers right above the ribs. We don't have those jet into the lung that much. But of course, not all places have 4 MeV electrons. And so, like, you know, we don't have we don't have, the lowest electron energy we have is 6 MeV. So if we plan this, then the dose might be a little bit deeper than what we hear. And so basically that's all I have. I'm going to say thank you for watching my presentations, and here's my email and contact numbers if you have any questions. Thank you. Yes.
Were you able to answer the questions that came in via question box?
Okay. Let me go there. So just exit out here, right?
Yeah, just you can actually drag it and drop it and extend it out of the toolbar so it's bigger for you.
Yeah. Okay.
While Coy's getting that, if anybody needs to get back to the clinic, you've earned your credits for the day. You are welcome to log off. If you'd like to listen to the questions, you can stay on.
So the only question I see is that someone mentioned, okay, hold on, let me make the question box bigger. So Spencer, how can I see the question?
Expand like any normal Windows window. Just grab a corner and then drag it.
Okay.
And then scroll down to the very bottom because I was asking a lot of questions in the beginning.
Okay. Okay, so the first case is, in most cases, we are able to keep the V20 for a lung below 35 gray. I was wondering what your maximum ipsilateral lung constraint is. For that one, we don't pay, honestly don't pay attention enough, but usually I think we are well below that. I mean, I can get back with you on that because I have to look through some of the other cases. Okay, another question is for the VMAT treatment. Does the physician still prescribe the use of bolus? We actually, on that plan, they did add the bolus. And so the patient would simulate with the bolus. But I think your question is that once we do VMAT, if we go ahead and put a bolus on after, I don't think so. Okay, and then the question is, how do they deal with tissue expander artifacts? With chest wall treatment, yeah, usually with the tissue expander, we would pull the CT scan in, and then I would have to contour the expander, and then I have to contour all the artifacts that is in the breast tissue, and then override it to 1, just for the artifacts, not the expander, and then we can continue with our treatment plan. Okay, another question is for your IMC fields. You mentioned physics, like about force. It's the width from the edge field to midline. Yes, it's just basically the entire width of the IMC field. Oh, do you use bolus for the electron chest wall methods? Yeah, sorry, I forgot to mention that. Yes, we for the electron chest wall, we do the bolus, and same thing is 2 to 5 millimeter every other day for 2 to 3 weeks. Another question is, do you ever use common ISO for 3 or 4 fields chest walls? I have heard that before, but we haven't used that here. Do you ever use two fields for the superclap? Anterior oblique, posterior oblique, the posterior oblique 18 MV for better posterior coverage, or are your superclap fields a single field? Okay, so for our superclap field, of course, when we have axilla involvement, then we would, yes, we would have what is called like a PAS, which is a posterior supplement, and usually it's just basically we put some margins around the that axilla area that we need to get coverage, and then yes, we normally use 18 MV, calc it to like a midline calculation point to get the coverage. Question: approximately how long does it take to plan each example you show today? Usually with the regular chest wall case, you know, we bring it in. It takes a while. Just take a little time to get we do some contouring out the wires. But usually once you contour out all that, get all the contours, and then of course all the fills, I would say that take maybe, you know, maybe 30 minutes, an hour, and then it may be another hour or so just to plan the chest wall case. Yeah, for the end, that one, it just depends because, you know, with VMAT plans, it can take a while to run all the iterations, and so, I mean, if you get, you know, if you run a few plans a few times and you get the coverage that you need, and the plan looks great, then it shouldn't take too long. But this VMAT plan, it took me a little while. I can't really remember exactly how long because we end up keep pushing the low dose as much as possible until we lose, we're starting to lose the coverage to the targets.
Is that all of them?
I just want to make sure I go down to see that I cover everything. Oh, do you ever use step and shoot? No, we for chest wall planning normally we don't use step and shoot. Now here where I work at, we do step and shoot to for our breast planning. The reason is that usually for chest wall planning, for the tangent portion, we don't really have. I mean, once we use a lot of wedges for the primary, and then it takes maybe only one or two fill and fill, or we call it like dose reduction, where we close the jaw to reduce the. And so, yeah, that's what we do. Just an extra one or two fill and fill. We get the 100%. Down to where we want it. Okay, so how is VMAT compared to proton chest wall irradiation? I know that our proton center have just started treating chest wall with proton, but as far as, you know, those comparison to the critical structure and coverage, I'm not sure on that. How many arcs do you usually use for chest wall cases? From what I've seen, I mean, for either breast VMAT or chest wall, which we haven't, but you can probably get away with just doing 2 arcs. That should be fine, one clockwise and one counterclockwise. The reason why I ended up splitting that one is because the arm was in the way, and I couldn't use the same rotations I could on the lower portion of the target.
Hey, Coy, make sure you answer Holden Wynn's questions. He just sent me an email, making sure he gets his.
Which one is it?
Holden, he's got a couple on there.
Oh, okay. Okay, Holden Wynn. Oh. Let me see. Okay, his question is, your upper and lower arc overlap? It looks like it's overlap on the VMAT view. Yes. I think I might overlap that by, I have to look closely, but usually I would overlap it by at least 2 cm. But I think on case I actually overlap by 3 cm, just to make sure to get the coverage to the targets. Okay, another one is, isn't 45 gray is low? We treat the whole chest wall to 50 and boost the patient to 60. Yeah, that patient, I asked the physician, and it's more of like a PAL case than a regular chest wall case, and so that's why she decided to go with the 45 gray instead of the traditional 50 gray. Okay, the question is, would you explain the bolus placement? I noticed the bolus was not covering the entire wall area. And which case you referring to? Maybe VMAT. If it's the VMAT, then I had to scroll through to see if they completely cover that with bolus or not. But in general, regular chest wall bolus for the superclap, I mean, they bolus the infraclap portion, and then for the, I mean, they bolus that, and that's what they do. They just place the bolus over the treatment field. Is there a review concern of the V5 for the VMAT chest wall plans? Yeah, I mean, yeah, I mean, definitely, I mean, we think that by using VMAT or IMRT, especially VMAT, you probably end up with a higher V5 versus like you use a traditional tangents and IMC, superclap. But that's why we normally don't do VMAT on our chest wall for breast cases. I mean, it's just on special cases where we can't get away with the regular setup. Okay, another question is, matching of electron fields can be a challenge, hot spot or cold spot. How do you get around with it? Usually match the electron fields on the skin. And then, like I mentioned before, usually between the IMC and the central the electron fields, whatever that hot spot is acceptable. I mean, the only one that we rule out is the angle between the lateral electron field and the central electron field. That one, we don't want too much gap in between there, because the bigger the gap, the bigger the overlap, and so that's where you get mainly the big hot spot when you have these electron fields. and with the hot spot, and we make sure that and then that's why we do a junction shift every week, 5 millimeter laterally, and just to make sure that we got all the cold spot and the hot spot. Yeah, the step-in shoot with common ISO. Yeah, I mean, I actually would like to see that. I just haven't it before because we always do the method that we have been doing here for a while. Okay, another question is the electron chest wall 3 show between the IMC and chest wall. And you always okay. Let me look rendering because I didn't plan this plan, but usually we definitely want to make sure we match it on the skin, and then there's no gap between the electron fields. Let's see. So that one, I'm not sure exactly what area that is not covering the chest wall. I don't know if you're referring to the bottom portion by the midline area or not. But yeah, like on this case, this is from the physician actually drew up this fields and make sure that it matches with the physicist before the dosimetrist got this plan to plan. Okay, next, the second photon for superflat fill out overlap with your chest wall electron to cover axilla nodes. How hot that would be on your BMI view, that axilla node is under the superflat ISO. Yeah, the step-in shoot with common ISO. Yeah, I mean, I actually would like to see that. I just haven't it before because we always do the method that we have been doing here for a while. Okay, another question is the electron chest wall 3 show between the IMC and chest wall. And you always okay. Let me look rendering because I didn't plan this plan, but usually we definitely want to make sure we match it on the skin, and then there's no gap between the electron fields. Let's see. So that one, I'm not sure exactly what area that is not covering the chest wall. I don't know if you're referring to the bottom portion by the midline area or not. But yeah, like on this case, this is from the physician actually drew up this fields and make sure that it matches with the physicist before the dosimetrist got this plan to plan. Okay, next, the second photon for superflat fill will overlap with your chest wall electron to cover axilla nodes. How hot that would be on your BMI view, that axilla node is under the superflat ISO. Photon.